Keynote address will begin. Our keynote address will begin in just a moment. I am pleased to introduce Dr. Brian Mittman, a senior scientist at Kaiser Permanente, Southern California Department of Research and Evaluation, who will be presenting our opening keynote today on implementation and conduct of pragmatic trials. You specifically will be talking about the intersection between learning health systems, quality improvement, and system science as it relates to pragmatic research. Dr. Mittman has affiliations at USC and UCLA, where he co-leads the UCLA CTSI Implementation and Improvement Science Initiative. He co-founded the IOM Forum on the Science of Quality Improvement and Implementation and the journal Implementation Science. He previously chaired the NIH Peer Review Panel on Dissemination and Implement Research in Health and directed the VA's Quality Enhancement Research Initiative, or the VA Query. He currently serves on the PCORI Methodology Committee, the AAMC Advisory Panel on Research, the NHLBI Board of External Experts, and advisory committees for several additional research and training programs. Please join me in welcoming Dr. Mittman.
Thank you, Bethany, for the introduction, the opportunity to speak, and to the other organizers and for the attendees for your interest. What I'd like to do is, as Bethany indicated, is talk through a series of arguments and points that talk about the relationship between implementation and implementation research and pragmatic trials, and draw from ideas, principles from fields as diverse as quality improvement or improvement science, learning health systems, and system level change. I'd like to begin by first making sure that I can advance my slides. There we go. Begin by repeating something which I hope that all of you have seen multiple times, and that is this quote. The Institute of Medicine has used this for a number of years. And it's one of the guiding principles, of course, for the field of implementation science, but is also directly relevant to the theme of this conference. We can think about pragmatic research as generating the knowledge, telling us what we need to know. But of course, we need to apply that knowledge, and that's where implementation, of course, comes in. And it also is not enough for us simply to want to implement. We actually must implement, and doing so, of course, is quite challenging. So I'll begin with a few brief comments talking about why implementation and implementation science or implementation research are important for pragmatic trials. I'll then talk through a series of implications of that assertion. Provide some guidance for integrating implementation principles and ideas into pragmatic research, and then talk about a few remaining challenges that face us as we attempt to operationalize and follow up on these ideas. So to set the stage and sort of provide the foundation for my argument regarding the importance of implementation for pragmatic research, I'd like to begin with a simple distinction between the kinds of research that we do when we are conducting efficacy studies versus effectiveness. So when we think about efficacy studies, they are meant to, for the most part, support policy decisions, and in some cases, practice decisions as well. So if we think about, for example, the FDA and drug research, the FDA is interested in knowing whether a drug works, whether it's effective, or whether it can be effective under idealized circumstances. They use the answers to those questions to determine whether it should be approved. Insurance companies, payers use the answers to these yes-no questions to make funding decisions and promotion decisions. Even within health systems, there are P&T committees that are faced with decisions to add or not add an innovative treatment or medication to the formulary. And even practicing clinicians oftentimes face this yes-no question: should I use this drug, this innovative intervention or not? If we think about not overall high-level FDA formulary decisions, approval and formulary decisions, but instead decisions that individual practitioners face, as well as patients and other consumers, they oftentimes face a set of decisions that go beyond simply, should I use it, is it effective, yes, no. They need to know how to use an innovation or an intervention and when to use it. And that's a theme that I'll come back to later on. But to get back to the key distinction between efficacy versus effectiveness research, again, we know that regulatory decision makers would like to know, can it work or does it work in general? Whereas practitioners often need to know not only how and when to use the intervention, but how can I make it work? How can we apply that knowledge? And I would argue that pragmatic research is meant to guide practice rather than simply to guide policy decisions. And so whereas efficacy studies can be deemed successful if they provide valid answers as to whether a medication, for example, is potentially effective, and as a consequence, they can ignore heterogeneity. Effectiveness studies need to account for the heterogeneity, the so-called other 85%. And this alludes to the findings from a number of studies that show that the very strict inclusion and exclusion criteria that apply to many efficacy studies result in only a very small subset of all of the patients with the indication of interest in being included in the study. So, you can think about that as basically stating that in many cases, an efficacy study provides valid answers to practitioners for 15% of their patients, but do not provide valid answers for the other 85%. So again, pragmatic research effectiveness studies are meant to guide practice rather than simply to support approval decisions. And this is partly related to the transition from research to support, again, approval decisions to evidence-based medicine and evidence-based practice. Again, the idea that research should support practice. So we know that outcomes improve when practitioners not only have evidence in the other insights and guidance they need, but when they can successfully apply that evidence. This is one element of the argument that implementation is integral to pragmatic research. And as a consequence, implementation science and implementation of research are integral to pragmatic research. Essentially, the argument is that pragmatic research cannot be or should not be conducted without very careful attention to implementation phenomena and without the use of implementation science principles and implementation science approaches. So let me talk through a series of aspects of this argument and some of its key implications. First of all, we know that in many cases, and this is especially true for complex health interventions, interventions such as health promotion programs and delivery system interventions, implementation interventions that have many moving parts or many components. We know that the outcomes of those interventions are heavily influenced by implementation processes. When we think about simple interventions such as drugs, we know that the outcomes of that drug are based largely on fidelity or adherence. If the patient doesn't take the drug, obviously it's not likely to have its desired impact. We know that for many complex health interventions, though, that again have multiple components, are highly adaptable, highly flexible, the way in which those interventions would be implemented and the resulting fidelity and adaptation and tailoring are strong determinants of outcomes. So again, one of the reasons why we need to attend to implementation processes and outcomes when we study effectiveness, even if our goal is only to develop an accurate measure of intervention effectiveness. We also know, however, that implementation processes and outcomes influence the delivery of the intervention. Our ability to successfully deliver a complex intervention or any intervention, again, determines its fidelity, and fidelity determines outcomes. So not only do we need to understand implementation to accurately measure effectiveness, but when we've completed our studies and we go to publish and disseminate and ideally facilitate implementation of the results of our pragmatic trials, we need to provide the audience, the target users of that intervention, with guidance for implementation. So again, another aspect of the argument that implementation is integral to pragmatic research. Now, what are some of the requirements for pragmatic research? Again, with a heavy focus on implementation. We know that decision makers need guidance in selecting appropriate interventions. We know that many interventions are highly dependent on context. and that a specific intervention that works in one type of setting is not likely to be as effective in another setting, and therefore pragmatic researchers need to provide guidance. We know, again, as I've indicated, and we'll address more fully later, that interventions are often highly adaptable and need to be tailored. And again, it's the function of pragmatic researchers to generate guidance for adaptation and tailoring, not merely to provide average effect size estimates or even some estimates of subgroup from subgroup analyses and others. We need to actually guide the local tailoring. I've talked about the need for guidance for implementation, both in introducing our interventions as well as supporting their ongoing use. Oftentimes, the outcomes that we are interested in improving are affected not only by the interventions that we deploy, but by many contextual factors. This is especially true in the implementation science and quality improvement field. The argument has been made that in the case of quality improvement, oftentimes the specific intervention that we select has relatively little impact on outcomes. It's features of the organizations that are much more influential in determining outcomes. Essentially, if we have a healthcare system or a set of clinics or hospitals with strong leadership and highly motivated staff that are well trained, healthcare systems and facilities with sufficient slack budget and staff to allow for quality improvement activity, for those kinds of high-resourced, high-functioning settings, we can actually deploy just about any quality improvement intervention, and they would make it work and they would improve care. Whereas low-resourced and low-functioning settings, even the most evidence-based effective quality improvement strategy may not lead to changes in outcomes and improvement because of the contextual factors and limitations and constraints on those outcomes and outcome improvement. So again, in some cases, the key to improving outcomes is not as much selecting an appropriate intervention, but instead working on the system and the context and providing support. And finally, the final bullet, those of you familiar with REAIM, of course, will recognize many of these dimensions. In order to succeed in conducting pragmatic research and achieving the overall goals of pragmatic research, which are to improve outcomes, we need guidance to maximize reach and adoption, as well as implementation, but also maintenance or sustainment and spread. And again, all of these are phenomena for which implementation and implementation science offer us important guidance. So let me now turn to a set of comments on how we can actually follow up on these implications in this argument. What is it that we can do as pragmatic researchers to integrate implementation and implementation thinking and principles into our research in order to maximize achievement of our goals? Let me begin by talking a little bit about one of the themes that you'll hear about throughout the conference, and that is the importance of engagement. When we think about the literature on learning health systems and embedded research and consumer and stakeholder engagement, we realize that there are actually three sources of knowledge that we need to bring to bear to improve outcomes. We start, of course, as researchers with science and research and the knowledge that we can bring to the table. We have knowledge of theory and general principles from past research. We have the ability to find and guide the application of existing empirical evidence and other insights from empirical research. And of course, we bring to the table our toolbox and our skills in using different study designs, research approaches, and methods. So when we think again about the partnership needed to successfully conduct embedded research, researchers, of course, and science have a lot to offer. But we know that researchers and research are necessary but not sufficient. We also need the service users or consumers. They, of course, have much better and richer insights into their own needs, their own values and preferences that we as researchers and scientists do. We need that information because we know that the adherence and fidelity and the supportive actions needed to achieve maximum outcomes require that those interventions be consistent with patient values and client and customer values and preferences. And as a consequence, thinking about the acceptability, the feasibility the value and the overall effectiveness of our interventions. All of this requires at the table representatives from the clients, the customers, the target users of our interventions. And finally, the third leg of the three-legged stool, and that is the service providers, the healthcare professionals, the public health experts and clinicians. They have the knowledge and skill to actually deliver the interventions that we develop and study. They have the knowledge and skills to collect and use patient and consumer values and preferences. Service providers and health professionals, of course, have their own values and preferences. So again, thinking about the likely acceptability of our research evidence and our research developed interventions, thinking about the feasibility of delivery of those interventions, and thinking about their overall value and effectiveness require that we have service providers working alongside us as researchers as well as service users. And again, you'll hear more about this throughout the conference and subsequent talks. So let me back up and provide the formal definition that the Institute of Medicine developed a number of years ago of the concept of learning health systems, and then talk a little bit more about embedded research and some specific strategies for achieving the three-part partnership that I just described. Learning health systems are systems in which each of these different contributors align to achieve continuous improvement in innovation. So we are routinely and reliably and consistently studying and learning and refining. And we do so in a true learning health system, not as a separate research activity, but instead as an integral part of the delivery experience. One feature of learning health systems is, of course, the approach in which we try to use data that were provided for and during the care process to conduct research. But the higher level idea, though, is this idea of continuous learning and feedback, and that has some key implications for the ways in which we design our studies and conduct them. Now, embedded research is a key element of a learning health system, as I indicated, is the way in which we operationalize or achieve the three-party partnerships that I described. Embedded research is defined as research activity that is located within a health system or a public health agency. And in contrast to pure scientific research, which aims to generate scientific or generalizable knowledge, and in contrast to pure quality improvement activity, which aims to achieve near-term improvements, embedded research is somewhere between those two ends of a continuum. Embedded research aims to simultaneously generate scientific knowledge at the same time that improves health system and public health performance and patient outcomes. This, of course, requires a full partnership versus intermittent input and involvement. It's more than simply conducting interviews and focus groups with service users or with health professionals, but instead having them serve as integral members of the team. Of course, embedded research is closely related to a number of other concepts and bodies of ideas, but embedded research is becoming more commonly recognized as the approach that we ideally would take in conducting much of our pragmatic research, again, in order to achieve the goals that I stated in my opening remarks, the idea that pragmatic research lead to improvements in outcomes in addition to generating useful scientific knowledge. Another key principle and another key implication of the importance of implementation rather, for pragmatic research is the need to attend to multiple levels. Unlike efficacy studies of drugs and even many effectiveness studies where we focus on only one level, if our goal is to facilitate changes in outcomes and to facilitate the appropriate implementation and delivery of the interventions that we are studying, we need to realize that healthcare outcomes, healthcare system performance, all of these are influenced by more than simply clinicians and organizational policies. We know that the community has strong influences. The health professions and professional associations have strong influences. Of course, regulatory organizations, the business community, and payers. Each of these are levels that combine to influence the behaviors and the outcomes that we are trying to change. And we need to be aware of each of these levels when we attend to implementation in our pragmatic trials. We're all familiar with the social ecological model. This is another depiction of that model that basically identifies each of the different levels or stakeholder groups that can potentially influence the outcomes that are of interest. The implication of this, of course, for those of us who are implementation researchers, is that we need to move outside the delivery system that we're studying and the point of care and focus on external context and all of these other factors. But that is true as well when we're thinking about pragmatic research. In order for our pragmatic studies to achieve their goals, we need to attend to each of these levels and think about how they influence the outcomes. We know that in the case of implementation research, going back 20, 30, 40 years, that we have a series of studies that have been conducted primarily at one or two levels, or that have primarily focused on one or two sources of influence. Back in the 1970s, the prevailing finding from studies of implementation and improvement strategies, or what at the time we called studies to change physician behavior, the most common finding was our intervention succeeded in changing physician knowledge and improving physician attitudes, but did not change practice. And the reason is that those practices are held in place or influenced by a number of other factors that were not addressed by the study. I'll often think about the goal of changing practice as akin to this gentleman trying to push the boulder up the hill. Not only is it obviously very heavy and steep, but we can also assume that that boulder is held in place by a number of ropes and bars and chains. If we address the educational factors, and if we address, for example, the skill deficits and the attitude issues, but we leave untouched the regulatory constraints or the payment constraints or the lack of time and equipment, that boulder ain't moving. So again, we need to think about the multi-level and multifactorial influences and constraints on practice and ensure that when we think about implementation, we think about the implementation strategies that are necessary to affect each of these constraints and each of these influences. This is one version of a checklist of the so-called necessary but not sufficient conditions in order to see implementation and practice change. We know we need the evidence as a foundation and we need knowledge and skill, but we also need supportive professional norms and community and social norms for patients. Our patients are not likely to accept the HPV vaccine, for example, if the community norms are counter to the goal of vaccinating. We know that oftentimes we need regulatory agencies and stakeholders to provide external expectations or incentives, as well as other fiscal and regulatory influences. We know that consumers need to be accepting of the evidence-based practices that we are promoting. We also know, though, that each of these first six conditions is not sufficient in and of themselves. We often attempt to implement evidence-based practices in settings where we have the appropriate knowledge, we have supportive professional norms, we have a supportive regulatory and fiscal environment, and consumers are accepting as well. The physicians, though, oftentimes will not change their practice if their perception is that they're practicing in accordance with the evidence. We need to actually provide them with evidence that they are not, that there are quality and implementation gaps. We need to understand the root causes of those gaps. And as I've indicated, we need to have enough time and space and other logistical arrangements. So again, the key theme here, of course, is that implementation is difficult, that our attempts to overcome implementation barriers require that we attend to all of those barriers and address all of the barriers that are keeping that boulder in place. So I've talked a bit about embedded research and multi-level interventions, but I'd like to spend several minutes now talking about complex health interventions. And the comments that I'd like to offer are actually relevant not only to the goal of ensuring that we appropriately attend to and address implementation issues in our pragmatic research, but they're also directly relevant to pragmatic trials of interventions that are multi-component, multi-level, that do have adaptable or tailorable components. So let me go back to this slide that I've used before and talk about the distinction between efficacy studies and regulatory decisions that are yes/no versus practice decisions that require us to know how to use an intervention, how to tailor and adapt that intervention. And again, the idea is that efficacy studies, for the most part, support this simple binary yes/no question. We conduct a large randomized trial. We measure outcomes for intervention versus the control group, or in comparative effectiveness research, we measure outcomes for intervention A versus intervention B. We often have the sample size to examine some subgroup differences and determine whether there are certain contextual factors or target population factors that do influence outcomes. But for the most part, our focus is on impacts or outcomes. And again, we're trying to answer the question, is this intervention effective? Does it work? For some drugs, of course, magic bullets, they're often called, the answer to this yes/no question is yes. This drug is highly effective for many or most patients, and therefore it should be approved and we should use it. Precision medicine, of course, is taking us down another path in which we do have extreme heterogeneity of treatment effects, and we do need to understand how to adapt or tailor drugs and other clinical treatments. When we deal with complex health interventions, though, health promotion programs, healthcare delivery, implementation strategies, we do have a very small number of these complex health interventions that are so highly effective and so highly robust that we can, in fact, produce an answer to the yes/no question. We can conclude after our research that for the most part, this intervention is effective across multiple settings, multiple time periods with multiple target patient populations. But for most complex health interventions, for most health promotion programs, most healthcare delivery interventions, most implementation strategies, and other multi-component interventions, when we conduct a study to ask, is it effective? The answer is invariably sometimes or it depends. We often see an average effect size estimate close to 0, but with considerable heterogeneity. So we can't, again, conclude this intervention is effective. It should be used across all settings. Now, to back up, what are some key features or definitions of complex health interventions? These are some of the key features that I've mentioned. Multiple components that target multiple levels or multiple entities. The intervention is highly adaptable. It can be changed in many different ways. And as a consequence of the multiple components and the adaptability and the multi-level nature, more often than not, those interventions achieve their effects through multiple pathways that are highly mediated and moderated. And I'll talk a bit more about that in a few minutes. So let me illustrate through a hypothetical pattern of results from an empirical study what this means for those of us who study complex health interventions. And again, I include in that category many of the kinds of interventions that we study in our effectiveness studies, our pragmatic research. This is a hypothetical guideline implementation study. We're trying to change rates of adherence to a clinical practice guideline. It is in a set of outpatient clinics. And as you can see in this study, the blue sites, which are the intervention sites, all achieved significant improvements in adherence and quality of care. Whereas the usual care sites on the left-hand side, there was some variation, but they're clustered around 0. So on average, the usual care sites showed no increase or no improvement at all. I don't know that any of us conducting implementation research or quality improvement or even pragmatic trials of other complex health interventions have ever seen a pattern of results like this. This is one of those, as I mentioned earlier, highly robust interventions for which the answer is a clear yes. It's effective. We should be using it routinely and widely. This is what we tend to see more often than not, as I said, when we study complex health interventions. We have very weak effects. The intervention group and the control group are both clustered around 0, and we have very high variance. So as you can see, there are sites in the right-hand side of this distribution that are control sites as well as intervention sites. So the implication is, or the interpretation is, that you're almost as likely to improve your outcomes if you get the intervention as if you don't get the intervention. And vice versa, if you look over on the left-hand side of the distribution. Almost as many intervention sites show decreases in adherence as usual care sites. If we see a pattern of study findings of this sort, there's no way, of course, that we would say this intervention is effective, everyone should use it. Our goal as researchers, when we're confronted with this pattern of findings, is to understand what determines which end of the distribution our intervention and control sites ended up in, and to understand how we can move more of the sites to the right-hand side of the distribution as opposed to the left-hand side. So it's a very different purpose for research, and I'll come back to that point later. So let me talk a little bit about why complex health interventions tend to show weak average effects and considerable heterogeneity. First of all, we know that the intervention targets or settings are highly heterogeneous. So we can argue with some validity, I believe, that patients who share a common physiology and genetic profile and other features tend to be more homogeneous than, for example, communities or healthcare organizations, clinics, hospitals. I mentioned earlier differences in culture and leadership and budget and staff training and so on. Those are just a few of the many features of intervention targets that make them highly heterogeneous. When we're dealing with behavioral interventions, again, patients tend to be highly heterogeneous as far as their a priori knowledge and skill, their attitudes, their values, their preferences. So heterogeneity in the targets leads to considerable heterogeneity in intervention effectiveness and outcomes. Heterogeneity in the underlying pathologies or the root causes of the behaviors or the quality problems that we are facing represent another source and contribution to heterogeneity in outcomes. To go back to my HPV vaccine example, we know that when we see low rates of HPV vaccination across sites, in some cases, it's likely that the clinicians and the healthcare systems are not doing enough because if they were providing brief interventions and following other evidence-based practices, they would achieve higher rates of vaccination. There are other settings, however, where the health system, the clinicians, the nurses are doing everything they can. They're employing all of the evidence-based practices, but patients and the kids' parents are highly resistant. So no amount of improvement in the system is likely to lead to significant improvements in HPV vaccination rates. We need to direct our attention to community norms and other factors at the community level. So again, differences in the root causes that require different kinds of interventions, but also lead to highly heterogeneous, highly variable outcomes and effectiveness of those interventions. And then finally, going back to one key feature of complex health interventions, and that is their adaptability. Irrespective of our efforts as good researchers to maintain fidelity and try to maximize internal validity, we know that when we deploy complex health interventions, they will be different, they will adapt, they'll change over time, and that we end up with considerable heterogeneity across place, across sites, but also across time. The organizational learning curve phenomenon tells us that interventions that are introduced and deployed in one manner during months 1 or 2 of a study, when we look down the road at months 5 and 6 and 11 and 12, we're likely to see that those interventions, those programs have changed, and that the organization itself has changed as well. So again, another source of heterogeneity and explanation for weak main effects and average effects, and the need for us to confront and deal with the heterogeneity directly. So one of the key requirements and recommendations for conducting pragmatic research is the need to begin with a theory-based causal model that depicts the different influences on outcomes and provides us with guidance both in developing the intervention and identifying the different levels that need attention and the different intervention components that are needed, But this kind of model also guides the design and the conduct of our study by identifying the mediators and moderators, identifying the contextual influences, and determining what we need to measure in order to understand mechanisms of effect and understand why, at the far right-hand side of this kind of causal diagram, we don't see the kinds of changes and improvements that we expect when we deploy our intervention. It may be that in this particular case, our leadership engagement intervention was weak and we did not achieve the level of leadership support, and as a consequence did not see the level of motivation and activation that would be needed. So I won't go through this in detail, but this is an illustration of the kind of causal model that we need to begin with in our pragmatic trials, especially of complex health interventions, and when we conduct implementation studies as well. Now, I've made this point previously, but to summarize, we know the complex health interventions usually can be tailored. They will be tailored irrespective of our efforts to maintain fidelity to a manualized intervention, but perhaps more importantly, they should be tailored. We know that we can improve outcomes through tailoring, and therefore as researchers, we should be embracing adaptation, we should be studying it, and ultimately we should be guiding it, rather than ignoring adaptation and heterogeneity or attempting to suppress it. I've mentioned before the importance of studies of studying mechanisms of effect, looking inside the black box, understanding processes of change rather than simply outcomes. Those of us who were kids back in the 60s and maybe even today remember the game Mousetrap. And this to me is a useful analogy to think about research. A typical clinical trial that focuses only on impact assessment would have us watching the beginning of the trap game where we drop the marble and then running to the end to watch to determine whether the trap falls or not. Or in the case of dominoes, we would watch ourselves flip the first domino and then run to the end to see if the final domino falls. If it doesn't, and if we haven't trained any of our data collection and analysis attention, focused our attention on the mechanisms of effect, we have no way of knowing where things went wrong and what to do about them. So again, the outcome is important, but what's more important is to study the mechanisms of effect, to document and collect data on the pathways, the causal pathways. There are a few other implications of this way of thinking. One of them, as I've implied, is that a manualized intervention is often counterproductive. If we think about developing a very strict set of rules and steps, or a very clear and explicit protocol, oftentimes that protocol may be optimal for some sites, but not other sites. And we need to provide ways of adapting and changing the intervention components in the way they're delivered in order to meet local circumstances. A similar argument can be made about the concept of core components, where those components are actually descriptions of intervention activities. Again, those intervention activities may be specific to the individual settings in which we conducted our research, but may not be feasible and may not be optimal for other settings. So there is a slow evolution in research on complex health interventions away from thinking about core components and thinking about intervention activities, and instead thinking about the underlying principles, or what Penelope Hall labeled the core functions versus the forms. This is a distinction and a framework that she introduced quite some time ago, but has been somewhat slow to take off. And the distinction, again, is between the core function of an intervention and the individual purposes or intended effects of its components, and the way in which those core functions are operationalized. We can think about, for example, patient education as a core function, whereas the forms include either use of printed materials or physician education, peer education. My HPV vaccine example is a useful example to use in thinking about the importance of patient education functions versus forms. A manualized intervention that specifies 3 minutes of physician brief intervention is likely to be effective for patients and parents who respect their physicians and will follow their lead, but in fact may be counterproductive for patients and parents who have an a priori belief that vaccines are dangerous and that physicians are somehow financially incentivized to prescribe them, even though they're harmful. We need to think not about the specific intervention component or activity or form, but instead the core function. And again, we need to study and embrace and ultimately guide local tailoring and decisions made as to which form to use under which circumstances. So I've talked, I think, about most of these issues. Manualized interventions, as they're typically understood and developed, can often be counterproductive. They put us essentially into a straitjacket and don't allow us to modify and tailor. We should be thinking about core functions rather than forms or core components. We should be thinking about new ways of measuring fidelity, not fidelity to the manual or the protocol, but instead fidelity to the underlying core function. And as I've said, main effect size estimates are not very useful when those effect sizes are likely to be close to zero. Rather than evidence as we typically understand it, we need to be thinking about the development of insights and understanding and guidance. So let me wrap up with just a few more comments. First of all, this is a list of some of the kinds of research methods that we should be using in our pragmatic trials and in our implementation studies in order to understand mechanisms of effect and to understand mediators and moderators rather than merely focusing on outcomes. This is a set of standards that come from the PCORI Methodology Committee that describe how to study complex health interventions or describe recommendations for studying complex health interventions. I've covered each of these in different parts of my talk. And again, the bottom line is rather than conducting our pragmatic trials with a focus on answering the question, is it effective or does it work? We need to try to understand how it works, why, where, when, and for whom it works. These are the key questions that our colleagues in realist evaluation highlight. And also, how can we enhance the effectiveness? Something we can't do very well with a drug that comes in a fixed chemical formulation. We can modify the dose perhaps, but we can't do much to modify the core content. We can modify the core content of our complex health interventions, and therefore we should be conducting research in order to guide that adaptation, that tailoring. This is a set of questions that we need to think about as we conduct pragmatic trials of complex health interventions and work to implement them. Again, we need ultimately to guide decision makers in understanding how, why, when, and where these interventions work and how they can adapt and tailor them and modify the context, the setting, in order to improve outcomes. This is yet another way of thinking about research in a set of steps for studying and ultimately using complex health interventions. And then some final comments about some of the other bodies of research that do provide some guidance for us. We know that the improvement scientists don't deploy a fixed intervention and come back 3 months later or 6 weeks later and measure outcomes, but instead they try things. Improvement scientists and other hard scientists will sometimes describe quality improvement activity as essentially throwing darts, where you continue to throw darts randomly, perhaps blindfolded, until you hit the bullseye. And at that point, you declare success and move on. On the other hand, the improvement scientists and practitioners look at us as researchers who deploy a fixed intervention and walk away and come back 6 weeks or 3 months later and ask us why we think the same intervention will be effective across different settings and why we feel that we can't modify that intervention. So obviously some combination of these approaches is necessary. And the key insight and principle from improvement science is the need for us to conduct real-time measurement and feedback and refinement. Again, we don't want evidence, we want insights and guidance, and we need to guide decision makers in how to use our interventions, how to tailor them, how to implement them in order to achieve the results that we are seeking. So just a final slide on some key outstanding challenges that we face. First of all, the need to conduct embedded research and partnership research. Is an embedded researcher in Kaiser and previously in VA. This one is easy, but is not so easy for researchers who are based in academic settings. Practice-based research networks, of course, provide a context, an infrastructure for embedded research, but you do need to develop these kinds of partnerships. Convincing funding agencies to fund work that examines how things work rather than do they work, with the longer time periods and the greater quantity of data collection analysis and the higher budgets is another challenge. We need to continue to develop and learn how to use and encourage the use of methods and designs that allow us to study mechanisms of effect, that allow us to study and guide adaptation and tailoring rather than suppressing it or ignoring it, and allow us to study and guide implementation. We need more guidance how to create and use theory-based causal models, how to measure fidelity to function versus form. One final note on the representative sampling paradox, and then I will wrap up. And that is one of many rules where the basic guidance differs for complex health interventions versus simple interventions. And briefly, when we are studying an implementation strategy or a healthcare delivery intervention, we're trying to predict the effectiveness of that intervention 3 years from now or 5 years from now when the study is over and we go to roll it out more widely. When we study drugs, we know that a random sample of patients that we take now is highly representative of a random sample of patients down the line, or the population of patients 3 to 5 years from now. When we study a set of organizations now using an innovative program that's completely unproven and where we don't have all of the insights we need to use it properly, the expected effectiveness of that program in a random sample of sites will be much lower than its effectiveness 3 to 5 years from now, when we have much better guidance and insights, when sites are more supportive of the practice because they see the evidence that it's effective, and when large health systems actually endorse or even mandate that practice. So the way that we develop a representative sample from that future state of affairs, when conditions are much more conducive, is for us to sample a set of high-performing, highly supportive sites, which under the standard rules of research would be viewed as a biased, non-representative sample, but in the case of these behavioral and delivery system studies, it's actually a more representative sample. So again, that's just one of many rules that differ, and point out that when we conduct pragmatic trials of complex health interventions, we need to recognize the distinctive features of those interventions. We need to recognize the importance of implementation, and we need to ensure that our studies are designed and conducted in a manner that achieve the goals of pragmatic research rather than that emulate our colleagues conducting effectiveness studies of simple interventions. I know that I'll have an opportunity to talk about some of the complex health interventions issues later. Other speakers will focus on other issues that I've raised. But again, I thank the organizers for the opportunity and wish all of us the best and for a successful conference and a great deal of learning. Thank you.
Thank you so much, Dr. Mittman. That was fantastic. Such a wonderful introduction to everything that we'll cover in this conference. So we'll now take about a 10-minute break and reconvene back in this very same Zoom room, so you don't even have to shut it down, for our Best of COPRH panel presentation that will be moderated by Dr. Amy Hubschman, and Dr. Mittman will be back for that as well. So thank you, everyone. We'll see you back here in about 10 minutes.